Good morning, everyone, and welcome to another session of TIRO MDS webinar. This is where each week we bring together leading experts around the world to discuss the latest advances in thyroid cancer and thyroid disease management. We're extremely fortunate this morning to have two of the giants in the field of thyroidology. Grace Segall is a senior advisor for real-world evidence in Eli Lilly. She holds a master's degree in biochemistry from University of Oxford, where she completed her training in epidemiology. It is very nice to have epidemiologists on our program to learn more about their vision of the clinical problem. So, Grace, we are very fortunate to have you this morning. Our discussion today is one of the true giants in the field of thyroid cancer. She is Lori Wirth from Boston. She holds the Elizabeth and Michael Ruane Endowed Chair in Medical Oncology at Mass General. She's attending medical oncologist at Mass General and also affiliated with Mass Eye and Ear. She works very closely with some of the well-known figures in thyroid surgery, Greg Randolph and other people, the entire Mass General crew who have developed and advanced the field of thyroid surgery and thyroid cancer. Lori actually trained in New York and then decided she couldn't take me anymore and decided to move to Boston, where she has done remarkably well. I can just introduce Lori by two lines, and that is her name is synonymous with thyroid cancer. And for the targeted therapies and the newer advances, I think there is nobody else in the United States who has made so much contributions. So Lori, we are very proud that you are here, and we look forward to your presentation. I just wanted the audience to recognize the voices of wisdom. This is presented every third week of the month. The current moderator is Dana Hartle from Paris. And this is a fund of knowledge that you will get in about 20-25 minutes that is unparalleled. I have heard many voices of wisdom, and I think they are superb. The latest one is, again, in advanced thyroid cancer by Dana Hartle and Mark Zaffario. It's wonderful. This is where you will learn a lot as an interaction one-to-one about the management of thyroid cancer. So without further ado, Grace, you are on, and later on I'll introduce again Lori to discuss the paper.
So thank you very much for the warm welcome and the invitation to present in this forum. I'll be presenting the manuscript Real-World Clinical Profile, RET Mutation Testing, Treatments and Patient-Related Outcomes for Medullary Thyroid Cancer Patients in Europe, which was published in the European Thyroid Journal in January 2024. So my financial disclosure, I am an employee and minor shareholder of Eli Lilly and Company, with nothing further to disclose. So medullary thyroid cancer is a very rare form of thyroid cancer, representing around 2 to 4% of thyroid cancers, but up to 15% of thyroid cancer-related deaths. The majority, around 75%, are sporadic medullary thyroid cancers, and around a quarter of the hereditary form. And the hereditary form can also co-occur with multiple endocrine neoplasias such as MEN2A or MEN2B syndrome. A large portion of medullary thyroid cancers have a mutation in rearranged during transfection or RET gene. So this is the vast majority of cases in the hereditary form of thyroid cancer, around 95%. Whilst in the sporadic medullary thyroid cancer, around 50% will have a sporadic mutation. However, there are also a small number of cases, around 10% of apparently sporadic cases, who have a germline mutation in RET. And so for this reason, the ESMO, the European Society for Medical Oncology guidelines here in Europe recommend that screening for RET mutations should be strongly considered in all patients with MTC for whom a treatment with systemic therapy is planned. In terms of systemic therapies available in Europe, this was at the time of writing the manuscript. Systemic therapies were largely of two categories, so the multi-kinase inhibitors, either vandetanib or cabozantinib, recommended for first-line therapy in advanced medullary thyroid cancer, or selective RET inhibitors later approved, for example, sulpicatinib. These were initially approved and recommended to treat advanced medullary thyroid cancer following prior treatment with cabozantinib or vandetanib. And then later, in September 2022, the EMA extended the approval of sulpicatinib to any line of therapy. So why do we need real-world evidence in RET mutation-positive MTC? Well, we see evidence that there are some more frequent indicators of poor prognosis, such as multifocal tumors and stage 4 disease that are observed in RET mutation positive disease, particularly with mutations in exon 15 or 16, compared to patients with RET wild type disease or another type of RET mutation. So it's possible that patients with RET positive disease have a more aggressive tumor type. We see in the USA, there's a fair amount of real world evidence that's been generated in medullary thyroid cancer. Just to highlight, I think the most recent publication in 2022 that also focused on a RET mutation positive population, Paracatal, a chart review between 2013 and 2018, which gave some insight into treatment patterns and RET mutation testing rate in MTC. But in Europe, there was, at the time of this study, much less evidence. There was a study performed in Germany in 2021, but it wasn't specific to RET positive patients. So there's still some remaining questions, particularly around the testing rate for RET and MTC, and also data on patient-reported outcomes in these patients. So in this study, we aim to describe the characteristics of patients and also their treating physicians in medullary thyroid cancer, RET mutation testing patterns and results, the systemic treatments received as well as supportive therapies, and then health-related quality of life. And this was in 5 countries in Europe. So the data for this study, we sourced it from the Adelphi disease-specific program. So our partners, Adelphi, are experts in real-world evidence generation, not just in oncology indications, but across therapy areas. And they have a method of collecting data called the Disease Specific Program, or DSP. So this data was sourced from a panel of physicians. And the first part was that the recruited physicians completed a survey which captured information around their attitudes and perceptions of treatments in MTC and the management of MTC patients. They also completed a workload form to get insights into their typical number of patients seen in clinical practice. The third part was completing a patient record form for each of the next 5 consecutively consulting patients who met the criteria for our study. So this was where the bulk of the information presented in this manuscript came from, directly from the records of these patients completed by physicians. And then a subset of the patients for whom a PRF was completed also completed a self-completion form, which captured data directly from the patient, including health-related quality of life reported by the patient and their experience of disease. So this data was collected between July and December of 2020. So importantly, before the approval of any selective RET inhibitors in Europe, and was collected across France, Germany, Italy, Spain, and UK, which I'll refer to as EU5 going forwards. So these survey methods have been previously published and validated, and there's references in the manuscript. All patients provided informed consent. The data was de-identified, and an ethics exemption from the Western Institutional Review Board was obtained. In terms of the selection criteria for our study, so the participating physicians had to have consultation with at least 2 or more patients with MTC or papillary thyroid cancer in a typical 12-month period, and be responsible for the management of these patients, including RET alteration testing and treatment decisions. Patients had to be 18 or over at the time of data collection, have a physician-confirmed diagnosis of locally advanced or metastatic MTC, and they visited the physician during the study period. So all of the patients included had a touch point with the physician during the study period. Patients participating in clinical trials were not excluded from our study. In terms of our analysis, we analyzed the overall advanced medullary thyroid cancer population across all countries. We had a subgroup of RET mutation positive patients, and selected results were presented by country and are included in the supplemental materials of the manuscript. In terms of missing data, we didn't make an allowance for missing data, and where data were missing for specific variables, they were excluded from analysis, including that variable. So that may explain changes in the base size of numbers for different analyses. So if I go into our study results, so to start with the physician characteristics, we had a total of 231 physicians for complete data in the survey. The majority of these HCPs were medical or clinical oncologists, around a quarter endocrinologists or diabetologists. And we also had a few radiation oncologists, endocrine surgeons, and other specialties. Approximately half of physicians practice in a public hospital, around a quarter in a cancer center. And we also had physicians from public offices or consulting rooms, private hospitals or offices. Physicians saw a mean number of around 9 MTC patients in the last 12 months, or around 55 thyroid cancer patients in the last 12 months. A minority, 8% of patients, of physicians were currently involved in clinical trials, but around a third had been involved in the past in clinical trials. If we go to the patient population included in our study, so we had a total of 275 MTC patients overall, of whom 79 were RET mutation positive. In terms of the country distribution, the country contributing the most patients in this sample was France, followed by Spain, Germany, Italy, and UK. The median age of patients in the study for the overall group was 60 years, slightly younger in the RET mutation positive group of 56 years. We had a very equal distribution of percentage male in both groups, 53%, and the majority of patients in this sample were of ethnic origin, white Caucasian. We saw that the majority of patients in this sample did have metastatic disease at the time of data capture, so 79% overall, and slightly higher in the RET mutation positive group, 87%, suggesting that these patients may have had more aggressive disease. 11% in the overall group had a family history of thyroid cancer, and higher in the RET mutation positive group, which may be expected, around 28%. If we look at the time between initial diagnosis and data capture, so the point at which this data captures a snapshot, in the overall population, this was approximately a year, 12.6 months, and longer in the RET mutation positive group, so around 21 months. If we look at the ECOG score at the time of diagnosis, we see that the vast majority of patients had an ECOG score of 0 to 1, so above the 85% mark. But if I go to the next slide, we see that that proportion did decrease if we go then to data capture. So whilst these patients are then receiving active treatment for the disease, we do see a lower proportion of patients had an ECOG of 0 to 1 and a higher proportion had an ECOG of 2 or above. The majority of these patients did have a calcitonin and a CEA test performed at diagnosis. And if we look at the distribution in the RET mutation positive group of patients who had co-occurring syndromes, we did have some incomplete data here, so we were missing for 41% of patients, but of those patients for whom we had that information available, we did see approaching a third of patients each had MEN2A or familial MTC, and a small number of patients had MEN2B co-occurring. If we look at genetic counseling offered to patients with a family history of MTC, we did observe that the majority of patients with familial MTC were offered genetic counseling as recommended in the guidelines at the time. And of those who were offered it, the majority did receive genetic counseling. Looking at the RET mutation testing patterns, and I took this figure from the sister poster that was released and presented at ESMO 2021 from the same study, just taking the figure from here. There's a lot of bars here, but if we focus on the far left, the total population aggregated across all 5 countries, the blue bar, we see that the overall testing rate for gene mutation, whether that was germline or somatic, was 75%. So the majority of patients were tested, and that corresponded to 207 patients. If we look at the smaller bars here, we saw that approximately a third of patients were tested for germline RET mutation, and just over a third were tested for both germline and somatic, and a small proportion, 16%, were tested only for somatic RET mutation. And then looking just across the countries, there was clearly some variation in the rate of RET testing, but fairly consistent, with just an outlier here with Spain with a higher 90% testing rate. This is a similar figure from the manuscript itself. The only difference being here, we're looking specifically at those patients, the 207 who received the RET test, so just a different denominator to represent the proportions who received. In red, 44% tested for germline and somatic RET mutation, 35% for germline RET mutation only, and 21% for the somatic RET mutation only. We also looked at the methods being used to test for RET, so we saw that just under half were tested by next generation sequencing. And it was shortly after this in the updated ESMO guidelines 2022 that they did say that NGS is the preferred method for testing for RET. 35% were tested by RT-PCR, and the remaining patients by immunohistochemistry or another approach. If we look at the RET testing results, this is a figure derived from the manuscript. If we look over on the far right total bar, we observed a rate of positivity in the testing of 38% overall, or 79% had a RET mutation detected. This was fairly consistent across countries, slightly higher in Germany and the UK. Another aspect that we looked at in the poster was the turnaround time for testing. So this was from sample acquisition to receiving results. So looking overall at the European population, we observed a mean time of around 3 weeks, 20.2 days from sample acquisition to receiving results. There was a fair bit of variation across European countries. We saw 9.6 days in Germany to 28.4 days in Spain. We also looked in the physician questionnaire at barriers to RET mutation testing. So again, there's a lot of bars here, but I'm just highlighting the total across countries. So the biggest barrier that we saw reported in 40% of cases was the high cost of testing at the time the survey was conducted. 29% then reported difficulty accessing the latest tests and genetic and genomic tests as a barrier. 27% reported the time delay in getting test results as being a barrier. And around a quarter of physicians each reported lack of physician educational resources or limited physician awareness. I think one interesting thing that we noticed looking at the barriers data and on the previous slide, the turnaround, the timing of the turnaround for the RET test, we saw that in Spain was the country who reported most frequently the time delay to getting test results as being a barrier. Which was interesting because we did indeed observe that that was where the turnaround time was the longest, which could suggest that if we can reduce that, maybe this really could be reduced as a barrier. If we move to the treatment patterns for these patients, so we did observe that the majority of patients did receive a first-line systemic therapy, so 69% overall and 82% in the RET mutation positive group. In line with treatment guidelines, we did observe that vandetanib and cabozantinib represented the majority share of treatments in the first-line setting. We saw slightly higher usage of vandetanib over cabozantinib in our sample, which could have been driven by a couple of things. Firstly, the vandetanib approval by EMA agency did come earlier than that for cabozantinib, so physicians could have had more familiarity with the drug. And secondly, it could be due to access, heterogeneous access across Europe. So we saw that France and Spain provided the majority sample, or they reported the most patients over the other countries in this sample. And it was in France and Spain where vandetanib was reimbursed, but not cabozantinib. And conversely, the UK contributed the smallest number of patients, and it's in the UK where cabozantinib is reimbursed, but not vandetanib. So could be due to heterogeneous access across the countries included. We did observe some use of chemotherapy in the first-line setting in these patients, which was interesting as it's not a recommended treatment in the ESMO treatment guidelines. Haven't included it here on the slide, but in the supplement, we did observe that the majority of this chemotherapy use was occurring in France. We noted that the majority of patients in the sample were still receiving their first-line treatment at data capture, which I've included here as context to over on the right, we observed quite a small number of patients receiving second-line treatment. This could be just due to capturing patients still on first line who haven't yet had opportunity to move on to second-line treatment. But again, we saw vandetanib and cabozantinib representing the majority of treatments here. We observed some use of larotrectinib, the NTRK targeted inhibitor, which is interesting in these RET mutated patients. In the manuscript, we also included a Sankey plot, which we quite often generate for studies looking at treatment patterns of systemic therapy to give us a bit more insight into the sequencing of treatments. On the previous slide, this tells us what treatments are received by line of therapy, but it doesn't tell us what the sequences look like. So this is quite a nice way to visually represent how patients move through different lines of therapy. So we do observe here that there are patients who receive vandetanib who go on to receive a different MKI, cabozantinib, or for example, start with chemotherapy and receive a multikinase inhibitor, vandetanib, in second line. If we look a bit closer at some of the characteristics of first line therapy, so if we look at the time from initial diagnosis to initiation of first line therapy, this was really relatively short in the overall population, 2.8 months. A bit longer in the RET mutation positive group, 7 months. If we look at the reason for discontinuing first line treatment among those patients who discontinued, the majority was due to disease progression whilst receiving treatment. We also saw some patients discontinuing in the overall group due to switch to hospice care. And in the RET mutation group, we had very small numbers here, but a patient request to stop treatment and unacceptable tolerability. We also looked at supportive therapies received by patients. One thing that we observed here was the use of levothyroxine was perhaps slightly lower than we might expect. We did look into this. We saw that only around a half of our sample received a thyroidectomy prior to starting systemic therapy, which could have been due to having unresectable disease at the time of diagnosis already. It could have also been due to, during our data collection, levothyroxine was classed as a line of systemic treatment, which could have driven some underreporting. And it could also be that levothyroxine was initiated a long time before the systemic therapy, which could have led to some underreporting. We captured adverse events during first-line treatment for this sample, and we did observe that just over half of patients overall, or slightly higher, 66% in the RET mutation positive group, did experience at least one adverse event during treatment. Most commonly in both groups, this was diarrhea or nausea. In the overall group, we also saw anemia, fatigue, and loss of appetite, and some of the more common adverse events. And in the RET mutation positive group, we saw fatigue, weight loss, and hypertension, as well as the more commonly reported ones. Another aspect of disease burden that we looked at was the symptoms reported by the patients during first-line therapy. So we did see that the vast majority of patients, 87% and 89%, did have at least one symptom during their treatment. So most commonly, bone pain, weight loss, cough, swelling of the neck or tender neck in both groups. And in the RET mutation positive group, we also saw voice hoarseness or change to voice and diarrhea as some of the more common symptoms reported. Our study did provide some insight into health-related quality of life of patients through that patient self-completion form. So just to walk through some of the instruments used here that not everyone may be familiar with. So the first two, these are not necessarily specific to cancer, but are widely used in economic evaluations. So the Eurocall visual analog scale, on which the patient scores their health state from 0 to 100 on a visual line. And that also has an accompanying section where they can rate their well-being across 5 domains: mobility, self-care, usual activities, pain, discomfort, and anxiety and depression. And locally, each country has tariffs that can be used to translate that into a utility that's used in economic evaluations. The FACT-G is a cancer-specific functional assessment of cancer therapy general questionnaire, where cancer patients can provide their physical, social, emotional, and functional well-being scores. And the work productivity and activity impairment questionnaire is a 6-item questionnaire measuring impact on work productivities and daily activities. So I think the key thing to highlight with these data is we didn't observe major differences between the RET mutation positive and the overall populations. Any differences that we saw here didn't meet previously published minimally important differences that have been previously published. But what we did observe was these the mean scores that we saw for these health-related quality of life measures were generally lower than previously published estimates for general populations without thyroid cancer across European countries, and particularly in the UK. And there was a study in the UK that also reported a similar analysis and reported that thyroid cancer patients did have lower health-related quality of life than the general population. In terms of the work productivity and activity impairment, we did see that in these patients, around a quarter in each group did report impairment to work activity, and around 45–46% reported impairment to their daily activities. We also captured information on the physician and patient perspectives on systemic cancer therapy. So physicians and patients had an opportunity to report the physician had an opportunity to report their reason for prescribing MKI or cabozantinib as first line of therapy. The top 3 reasons were progression-free survival benefit, overall survival benefit, and recommended by national guidelines. We saw quite similar results reflected in areas for improvement in the current or most recently received MKI, looking for improvements in overall survival benefit, progression-free survival benefit, and high response rate. Here is quite interesting. We have the physician and patient goals of treatment other than a cure reported. So at the top, this is what the patient reported as their goals for treatment, for being the most important benefit. So they ranked increased overall survival, help you live longer, and improve quality of life. And we saw very similar from the physicians, but the other way around. So improving quality of life was reported most frequently as the physician reported goal, followed by increasing overall survival. So to summarize some of the key results and discussion points, starting with the characteristics of RET mutation positive patients and the burden of disease that we observed. So we did see a numerically higher rate of metastatic disease in the RET mutation positive group compared to overall, 87% compared to 79%, which could be consistent with prior evidence that these patients have more aggressive disease. We saw some indicators of disease burden in these patients. So we did see that the ECOG performance status deteriorated from initial diagnosis to the time of data capture. We saw that most patients were symptomatic whilst they were receiving their first line therapy. And looking at health-related quality of life, work productivity, and activities of daily living, we did observe some impairment in the overall population and the RET mutation positive group compared to mean scores observed previously from general populations. This was consistent with a prior UK study conducted in the UK showing the same. We also observed a relatively short 2.8 months time from initial diagnosis to initiating the first line systemic treatment, which could suggest the presence already of quite aggressive disease and the need for a timely diagnosis for these patients, initiating treatment to provide local or regional control of the disease. In terms of RET mutation testing and the prevalence for RET, we did observe that 3/4 of patients in the sample were tested for RET mutation. This was in 2020, remember when the data was collected. But we still saw an absence of testing in 25% of patients, which was at variance with the guidelines from ESMO at the time of the study. We can expect that this could have increased since 2020, since the introduction of selective RET inhibitors such as sapacatinib. This was the rate of testing was similar to what was observed in Parekh et al. In a similar US study where data was collected by a chart review in advanced medullary thyroid cancer patients. So a little bit higher, possibly explained by a later study period. We got insights into the most frequent barriers to testing. So these were cost, difficulty accessing the latest tests, and the time delay for testing results. And as we saw, that time of testing results did correlate with the turnaround time that we observe in countries, suggesting that if we can reduce turnaround time for testing, that could indeed release this as a barrier for testing. And we saw a prevalence overall in the MTC population of 38% with RET mutation positive. And this was incredibly consistent with Parekh et al.'s US study, where they saw 37% positivity rate. Considering the treatment patterns in RET mutation MTC, well, in the overall population, we did see cabozantinib and vandetanib as the most commonly used first-line treatments, with vandetanib use being more commonly used than cabozantinib. possibly reflecting the earlier regulatory approval for vandetanib and the country distribution that we had in our sample and different access to those treatments. This was in line with ESMO guidelines at the time and was also consistent with the treatment patterns observed in the US in that study. We did see a slightly higher use of MKIs in the first line in RET mutation positive patients. This could be related to or kind of explained by a higher rate of metastatic disease observed in patients with RET mutation positive MTC, maybe suggesting that physicians considered a RET mutation positive patient more suitable for treatment with an MKI compared to those who were RET mutation negative or were not tested. And that concept could be supported by the large proportion of physicians who reported suitable for patients with RET gene mutation or fusion as a reason to prescribe MKIs to RET mutation positive patients. We did observe a small number of patients receiving chemotherapy in first line, despite this not being a recommended guideline by the ESMO guidelines. And we did observe a lower rate than expected of levothyroxine use. Again, we looked into the rate of thyroidectomy, which was relatively low, around half of patients in our sample, and it could be due to some nuances in how we collected the data, how levothyroxine was classified in our data collection form, leading to some underreporting. But the idea that this could be due to a low thyroidectomy rate, and that this could be because patients had unresectable MTC at the time of their diagnosis, was supported by a short median time, around 3 months from initial diagnosis to first-line systemic treatment. Some study limitations that we highlighted in our manuscript was that the selection of specifically consulting patients could have led to an overrepresentation of patients who consult more frequently with the physician compared to those patients who may have been on sort of watch and wait strategy after immediate diagnosis. And the exclusion of deceased patients meant that we couldn't look at an outcome measure like overall survival in this study. So we only included patients who were alive during the study. Not called out in the manuscript or a limitation per se, but this data was collected before the availability of selective RET inhibitors. So provides a window into treatment patterns prior to that time. So in conclusion, our study in these European countries prior to the availability of selective RET inhibitor has highlighted the burden of disease and treatment in patients with medullary thyroid cancer and the need for improved therapy. Identifying patients who are eligible for treatment with selective RET inhibitors can be achieved through increasing rates of RET alteration testing in routine practice. And RET testing can be optimized by increasing the testing rate for germline RET mutations, followed by somatic RET mutation testing in patients with negative germline testing results. I've included all my references at the end of my slides. Thank you very much. I will stop presenting and turn it over to Dr. Wirth.
Thank you very much, Grace. That was wonderful. I think this gives us the better perception of what we do in the United States and the rest of the world. And I'm sure Dr. Wirth will discuss more about the cost of these drugs and the availability of these drugs. But I'm very happy because we have several endocrine surgical friends in Europe who have advanced the field of medullary thyroid cancer in that part of the world, especially in Italy with the great Dr. Aldo Pinchera and Rosella Alessi. I think their work is monumental. So we're very happy to hear your presentation, especially what we don't understand much about the patient-related outcomes and the physician. I think what is the physician perception? I think that's why this paper deserves a lot of credit. It is a wonderful work, and congratulations. We'll look forward to listening to Dr. Wirth, who is one of the pioneers in the field of medullary thyroid cancer and advanced thyroid cancer. Lori, the floor is yours.
So thank you very much. And Grace, I was really glad to see the paper and the presentation. It's so interesting to see what's being done on the ground. And then also the parallels between Europe and what we do in the US were striking. And I was definitely a little bit surprised to see that. So I'm going to do a little bit of background, if I can advance my slides. Here are my disclosures. So some of this, I apologize, might be a little bit of repetition. I'm just going to go through some background really quickly. Of course, RET alterations are a very important driver alteration in medullary thyroid cancer. And then most of the RET wild type MTCs are driven by RAS point mutations. There are other oncogenic alterations that are relevant, however, in medullary thyroid cancer, including EGFR and c-MET overexpression, VEGFR overexpression, and angiogenesis. But of course, we really care about RET. And as Grace already reviewed, 25% of the MTCs are hereditary, and all of those patients will harbor germline RET mutations. But of the 75% of MTCs that are sporadic, 60% of those patients will harbor somatic RET mutations. So when all is said and done, a majority of patients with MTC will have a RET mutation that's a driver alteration. So RET M918T is the most common somatic mutation. So that's the most common RET mutation that we see in medullary thyroid cancers. RET C634 is one of the more common hereditary mutations, but that can also occur somatically. And it's important to know that there are more than 100 mutations, duplications, insertions, and deletions involving RET that have now been identified in medullary thyroid cancer. So one of the other reasons why we care about RET is because it's a receptor tyrosine kinase. And if it's a driver alteration, it should be druggable. Interestingly, in thyroid cancer, RET is particularly relevant because it is mutated, driving a majority of the medullary thyroid cancers. But we also see RET rearrangements driving about 10% of papillary thyroid cancers. And both of those two different types of alterations give rise to the same phenomenon of ligand-independent signaling and oncogenesis. Oops, did I go? Oh, so I think that went the wrong way. Okay. As Grace mentioned, we do have several drugs in our arsenal prior to the RET-specific drugs, namely, I'll focus on cabozantinib and vandetanib. So this is a kinome dendrogram and showing all of the kinases present in the human body, and then the balls represent the kinases that the different drugs inhibit. So you can see that cabozantinib and vandetanib inhibit a number of different kinases, including KDR or VEGFR2, and then RET is represented in the green ball. So they both have anti-RET activity as well. And those two drugs were approved for medullary thyroid cancer based on the ZETA trial with vandetanib and the EXAM trial with cabozantinib. Both of those studies compared the drug to placebo with progression-free survival as the primary endpoint, showing a significant improvement in progression-free survival with both of the two drugs compared to placebo. They work, they're good drugs. The problem is they also cause side effects that really can impact on how patients feel. Hypertension, hand-foot syndrome, diarrhea, anorexia, nausea, weight loss, fatigue are all common adverse events related to these VEGFR multikinase inhibitors. These can really impact on patients' quality of life. There are more rare but potentially serious adverse events, including thromboembolic disease, fistula formation, and then prolongation of QT interval. So most patients on these drugs do have to have a dose reduction in order for the drugs to be tolerable. And then in the two trials, there was treatment discontinuation due to adverse events in 12% of patients on vandetanib and 16% of patients on cabozantinib. So that's a fairly large number of patients who just can't tolerate these drugs. Fortunately, however, we now have RET-specific agents in our arsenal. I'm going to talk mostly about selpercatinib. The development of pralsetinib in medullary thyroid cancer was discontinued, not because it's not a good drug, but more for practical reasons. But both of these drugs were designed similarly to potently and specifically inhibit RET as much as possible and have as little off-target inhibition as possible, with the idea that the side effect profile with VEGFR multikinase inhibitors primarily comes from the inhibition of VEGFR2, and then with the VEGFR multikinase inhibitors, because of that VEGFR2 toxicity, it really limits the amount of anti-RET inhibition that can be driven up with those drugs. If you have a RET-specific inhibitor, you should be able to more potently suppress that driver alteration in medullary thyroid cancer. So the Libretto-001 trial was the first in human phase 1/2 trial of selpercatinib in patients with RET-altered cancers. There were a few different cohorts, non-small cell lung cancer cohorts, and then thyroid cancer cohorts. I'm going to focus on the two MTC cohorts. One was patients that had been previously treated, and one patients who hadn't received any prior therapy. But in terms of the safety profile of selpercatinib in medullary thyroid cancer, this busy table shows that patients do experience some adverse events, not all treatment-related, but of any grade treatment-related adverse events, they're fairly common side effects. Most, however, are grade 1 or grade 2. So if you focus on the grade 3 or higher treatment-related adverse events, you see a lot of 1s and 0s in that column. The most common grade 3 or higher treatment-related adverse events with selpercatinib were hypertension, transaminitis, and diarrhea. Now, only 30% of patients had to have dose reductions due to treatment-related adverse events, and only 2% of patients had treatment discontinuation due to a treatment-related adverse event. So here we see the efficacy of selpercatinib from Libretto-001 in patients that were previously treated with cabozantinib, vandatinib, or both. And even in this previously treated patient population, we see great activity with an objective response rate of almost 78%. And in the latest data cut, we have now reached the median progression-free survival of 41 months and median overall survival of 64 months with previously treated MTC patients on selpercatinib. In terms of the patients that were cabozantinib and vandatinib naive, it looks like the objective response rate might be a little bit higher, almost 83%, and the median PFS and median overall survival have not yet been reached, despite a number of years of median follow-up now. So it was on the basis of the Libretto-001 study that selpercatinib garnered an accelerated approval by the FDA for patients with RET-altered cancers. Those beautiful data led to Libretto-531, which was a randomized phase 3 international trial comparing selpercatinib to physician's choice, cabozantinib or vandatinib, in patients with treatment-naive medullary thyroid cancer. When patients had disease progression and were on the physician's choice arm, they were offered crossover to selpercatinib at the time of disease progression. Now, the regulatory bodies did not require blinding of the treatment arm because they accepted the idea that we're going to know, because of the side effect profile, what arm the patient is on. So the primary endpoint of Libretto-531 was progression-free survival. There was, however, an important secondary endpoint, which was treatment failure-free survival, and I'm going to show you those data in just a minute. But this shows the progression-free survival. This was by blinded independent review. And you can see that the PFS with selpercatinib was really significantly longer than was seen with cabozantinib or vandatinib, where the median PFS was 14 months. And at the most recent data cutoff, the median PFS for selpercatinib has still not yet been reached. So very statistically significant improvements in progression-free survival. The hazard ratio was 0.2, which was really a strong hazard ratio. The objective response rate in the initial publication showed the objective response rate to selpercatinib was 69% versus 39% in the control arm. However, with longer follow-up, we're seeing higher response rates over time. So it turns out that some patients can respond very quickly. Other patients take a number of months before achieving a partial response. Now, this shows the Kaplan-Meier curves for treatment failure-free survival with selpercatinib compared to vandetanib or cabozantinib in Libretto 531. And this was defined as progression-free survival plus drug discontinuation due to a treatment-related adverse event. So basically, it captures how long patients are able to stay on the drug that they're benefiting from and also tolerating. And I really like this endpoint because this is, of course, what patients care about the most, I think. You can see that selpercatinib was significantly better than cabozantinib or vandetanib in terms of T. And here we see the overall survival Kaplan-Meier curves. So it does appear that overall survival is favored with selpercatinib over control. However, this wasn't alpha controlled, so we can't make a definitive statement that overall survival was indeed improved with selpercatinib compared to the control arm. And then I wanted to show you this tornado plot representing the treatment-related adverse events that were seen in patients. So orange is selpercatinib, blue is the control arm. The light colors are grade 1 and 2. The darker colors are grade 3 and 4. And I think you can see just eyeballing this tornado plot that you do see more adverse events with cabozantinib or vandetanib as compared to placebo. So overall, selpercatinib significantly improved progression-free survival, TFFS, the objective response rate was better, and the toxicity was significantly better as well. So Libretto 531 did lead to full approval by the FDA in 2024 for selpercatinib in RET-mutated medullary thyroid cancer, and then also received a conditional authorization by the EMA in 2021 that was updated a year later, I believe, for any line of therapy. So, of course, with the availability of selpercatinib now, testing for RET and medullary thyroid cancer patients really is critical. So what do the guidelines say? The ATA is just woefully out of date. The ATA guidelines for MTC were published in 2015, long before there was any hint of RET-specific therapy. So we're eagerly awaiting the new ATA guidelines that will hopefully really provide updated guidance for how to test for RET and MTC patients. In the ATA old guidelines, there's basically discussion about germline RET testing only. Those guidelines are great, but there's no mention at all of somatic RET testing. Now, in terms of the ESMO guidelines, I grabbed this screenshot of the flow chart here because it's a really nice picture. Flow charts work really well, but I'm so disappointed to see that the flow chart doesn't even mention RET testing at all. And so it's a pretty picture, but I wish that RET testing was given more of its due in the ESMO guidelines. There is, however, some guidance in the ESMO guidelines on RET testing and MTC, suggesting that NGS testing is the preferred detection of RET mutations in patients. And then there's also guidance on treatment with MKIs or selective kinase inhibitors in the ESMO guidelines. So the ESMO guidelines are a little bit less out of date than the ATA guidelines, but still there isn't really good guidance on how how exactly to test for RET in MTC patients. What about the NCCN guidelines? So they're a little bit more granular. There is guidance for screening for germline RET mutations in patients and offering genetic counseling as well. And then in the NCCN guidelines do call for somatic testing for RET mutations in patients that are germline wild type or unknown when patients are going to need systemic therapy, whether they have local regionally recurrent disease or distant metastatic disease. But despite that, there still, I think, is a lot of question on how do we optimally test for RET mutations in patients, because it's confusing. There are the germline mutations, there are the somatic mutations. Germline RET testing is usually done with genetic counseling. That can take forever. NGS testing of tumors can come back in 10 days or 2 weeks. And if a patient needs therapy, maybe you should do that first. And then I did just want to highlight in the NCCN guidelines that selpercatinib is the preferred category 1 treatment option for patients with RET-driven medullary thyroid cancers. So getting to the really interesting real world paper that Grace shared with us, I think that what we're seeing is that prior to the approval of selpercatinib, RET testing is being done, but only in 75% of patients did they have any RET testing done. That means that 25% of patients didn't have RET testing done. 35% had germline only RET testing. And so we would, if that is what's being done on the ground now, about 40 patients in those 275 patients would harbor a RET alteration that went undetected, and they had advanced medullary thyroid cancer and needed treatment. So that's a lot of patients who wouldn't have access to the optimal therapy for their disease. And then 21% of patients had somatic testing only. So if you have a somatic RET C634 mutation, would that patient not have been referred for germline testing? Or were all of those patients referred for germline testing so that we know that no MEN2 patients might have been missed? We don't really know the answer to that question. And then interestingly, 44% of patients did have both germline and somatic testing done. And should we consider that this is the gold standard for RET testing in all MTC patients or in all advanced MTC patients? It's actually not really well worked out. And I think that what we really need are very granular guidelines on how to optimally personalize RET testing for each and every medullary thyroid cancer patient. If the patient has a family history or personal history that's suggestive of MEN2A or 2B, of course they need germline RET testing. If the patients are single, don't have any family members alive, really don't want to have germline testing done, perhaps that's fine. But for patients that have family members that could be at risk, then germline testing also should be considered a must for every MTC patient. But what if the patient needs a prompt initiation of systemic therapy? The turnaround time for tumor NGS testing is really fast. So we go to that here, and we don't send patients to genetics counseling for germline RET testing if they need to start systemic therapy right away. But should those patients that have tumor NGS testing also have germline RET testing? We really need to have these very specific guidelines elaborated for those of us, especially who don't see MTC patients every day. I also thought it was interesting seeing the MD barriers to testing. Cost, of course, is always an issue, and that we can only do so much about. But which assay is best? We need guidance on that spells this out clearly in a very accessible manner, so that a physician who sees MTC patients maybe once or twice a year doesn't have to deeply research what test should I use, but the guidelines provide that for us. And then in terms of systemic therapy, 69% of patients started on first-line vandetanib or cabozantinib, which really seems quite appropriate. But now, of course, 82% of the patients in the study were RET positive who started first-line vandetanib or cabozantinib. Would more patients now be starting first-line selpercatinib? I think that those RET mutated patients would certainly say they would want to. And I think it's important to know that sequencing is important with treating RET mutated patients, because we do see that selpercatinib works better in the first line compared to the second line, shown in that chart there from the Libretto 001 trial. The median PFS in first-line patients still has not yet been reached. Median OS has still not yet been reached, whereas those medians have been reached in the second-line setting. So selpercatinib works better longer in patients who haven't received prior vandetanib or cabozantinib. And then libretto 531 showed that the efficacy and safety really is truly superior to vandetanib or cabozantinib with selpercatinib. And patients and physicians prioritize quality of life and survival. We know that from the real world study here. Now, I did want to also highlight what Grace highlighted. 22% of patients got first-line chemotherapy. And I would just like to say, what's up with that? Presumably, 36 of these patients would have approximately would have harbored a RET mutation had they been tested. I don't think that we should at all be thinking about chemotherapy as a first-line therapy in a RET-positive medullary thyroid cancer patient, let alone a RET wild-type patient. So I'm going to wrap up here and just again highlight that RET mutations do drive a majority of the medullary thyroid cancers. Germline RET status is necessary in nearly all of MTC patients, having major implications on not only the patient's own health, but also on their family members. And now that RET-targeted gene-specific therapy, namely selpercatinib, is available, highly effective and well-tolerated, the RET status needs to be determined for all patients who we expect are going to need systemic therapy. This should include somatic RET status in germline wild-type patients or in germline unknown patients. The RET testing, optimal RET testing for each patient is really quite nuanced, and we really need updated guidelines to make it more granular for us. And I think that the real-world European experience indicates that there are significant unmet needs in both testing and treating patients with RET-positive MTC. So let me stop there and stop sharing my screen, and hope we have a few minutes left for conversation. Oh my gosh, I'm seeing it's 9 o'clock.
Thank you very much, Dr. Wirth. That was wonderful. I think you summarized the whole subject. Clearly, this is a very complex subject, and we are close to the hour, but I'm going to give a chance for Grace to respond both to your some of the questions you raised and some of the points that she already alluded to in her presentation. So Grace, you have got 1 minute. Go ahead.
Yeah, sure. I wanted to thank you, Dr. Wirth, for the really insightful expert presentation there. Really fantastic to see the positive results from libretto 001 and libretto 531. I think in terms of closing the RET testing gap, I think the more we can do of disseminating that evidence and generating real world evidence on selpercatinib in routine clinical practice, which we're doing here at Lilly. I have another ongoing study looking at the real world use of selpercatinib in medullary thyroid cancer to complement what we're seeing in the trials. I think disseminating the good clinical data would really help us. I think, in response to the question on chemotherapy, which was unexpected and what we saw, I think one thing we didn't look at was the year of treatment initiation for those chemotherapy treatments. And I do wonder if maybe some of those patients in our study initiated chemotherapy before availability of MKIs. Maybe that's what we're seeing there. Would be interesting to look at that.
The other thing I was wondering is maybe some of those, a few of those patients might have received chemoradiotherapy after surgery for positive margins, et cetera. That's something that we used to do. We don't do any longer. I think, Ashoki, I'm sure that you have the same experience at Memorial, where we were much more selective in using radiation, especially concurrent chemorads in these patients.
Yeah, we are extremely selective of radiation in medullary thyroid cancer. I think, just like anaplastic, this is one disease where we get input from everybody. And I think our radiation oncologists are extremely selective when we want to use the radiation. Actually, in the Endocrine Society, they are very particular not to use radiation unless it is going to make a major difference. Number one, in the outcome of the patient, the longevity and progression of the disease in the central compartment, leading to tracheal involvement, etc., or requiring laryngectomy in future. So I think the whole idea of radiation, along with the selpercatinib and other drugs, has revolutionized the entire management of thyroid cancer. I just want to make one last comment. The germline mutation, which is not done regularly in Europe. I was surprised with that because in the United States, we strive to do it on every patient, and not because of the care of the patient, but for the family members who need to be studied. And certain family members may have incipient medullary thyroid cancer, which can be attacked readily. Dr. Wirth, you have a comment on that?
But I think that your point is very well taken. There really is a duty to test for germline RET mutations, because it's not like ALS, where if you know you're going to get it, you can't do anything about it. Patients harboring a germline RET mutation who don't have an established medullary thyroid cancer can have a prophylactic thyroidectomy at the appropriate time and prevent them from ever getting a cancer that could otherwise kill them.
Thank you very much. Since we are close to the end of the hour, I think I would like to conclude. Once again, Grace and Dr. Wirth, thank you very much. Wonderful presentation, highly educational. Next week, we have a treat from Dan Schoenfeld, who will be talking about the high-grade follicular thyroid cancer, and subsequently, the remaining two this month will be a tumor board with Michael Tuttle. It will be wonderful. And Susan Mendel, one of the extremely well-known personality in thyroid ultrasound, will be discussing presentations. So look forward to TIRO presentations. Thank you very much and have a great day.